Bien, donc je voulais faire avec vous un point sur la prise en charge. Alors on peut dire beaucoup de choses sur l'anémie. Il y a un focus dans cette présentation sur la question de la prise en charge à visée curative. Vous voyez, j'ai mis double guillemets pour les pathologies cancéreuses. Double guillemets, pourquoi? Parce qu'il y a relativement peu de situations curatives en dehors de l'adjuvant en oncologie médicale, comme les tumeurs germinales, etc. Mais il y a aussi des situations dans lesquelles on procure de gros bénéfices de survie aux patients. Et c'est probablement là.
Apologies for this technical difficulty. The interpreter is trying to identify the representation. I'm going to skip part one rather quickly because we're running out of time, and I wouldn't want to insult you by reminding you, as I would do with my children or my students, that there are multiple factors involved in cancer. But just because you have anemia doesn't mean you have to prescribe ESAs. You need to look at the etiology. And in cancer, etiology is significant. As you well know, there are recommendations, there are guidelines that focus on a particular but very important point in terms of handling cancer-induced anemia. Sarcopenia. There are various contributing factors. Bleeding in particular is frequent in cancerology, but there's another well-known phenomenon. Macrophage sequestration and inflammatory syndrome. As you know, there is a rather simple but true idea that we need to disseminate oral iron in case of medical oncology has little or no indication, and we need to administer iron IV. So sometimes IV iron is enough to correct the iron deficiency, which means that you can avoid other treatments, and other times you need to combine the two. We tend to say that, of course, we don't transfuse a figure, we always transfuse a patient, so it's a compromise between how severe the anemia is and the patient's symptoms. So our clinical focus is important. However, there is data here between correcting quality of life factors, including fatigue and the hemoglobin factor rate between 11 and 12 gram per DL. We are not bad from equality improvement in the patient's general status as well as his fatigue status. So the objective is twofold, and it is a figure on the one hand and also the general health status of the patient. So clearly, when we correct anemia using ESAs, we obtain a more consistent hemoglobin concentration. The correction is less random than if we use the successive transfusions. So we can therefore imagine that this type of correction would, in theory, be the right thing to do. I will spare you all the data that you know well in terms of correcting fatigue and also depressive symptoms by correcting anemia. How do we ESA and ESAs have been looked at by dozens of studies. I decided to focus on one thing: survival. PFS and OS for patients who receive hematopoietic stimulant agents. Out of thousands of randomized studies, a number of studies have actually brought in surprises in terms of survival criteria. Survival criteria were always secondary criteria or endpoints. So 8 studies. There are studies that we will get back to, but most of them are chemotherapy, particularly for metastatic breast cancer, particularly the BEST study, and there are studies that were carried out within the context of radiation therapy, particularly for ENT patients. So ESA while receiving radiation therapy, and also in supportive care. But ESAs were administered to improve the patient's comfort. If we look at this particular situation, which is, well, highly curative, and I'm using air quotes here, the survival benefit is significant. There are 2 different situations. For a metastatic breast cancer, for example, the BEST study by Leyland Jones, it was surprising, but there's a difference in terms of overall survival between patients who received epoetin alpha and the other patients who did not, even though there was no difference in terms of PFS. And as far as the adjunct is concerned, the PREPARE study also brought in its lot of surprises with a reduction. Well, that is barely statistically significant, but it's interesting in terms of PFS. This chart is a bit complex, I know. It's a summary of the various studies, and we're trying to show you the following thing. The key targets in terms of hemoglobin rates from many of these studies, the targets are different than current guidelines. In most guidelines, you should not exceed 11 or 12 gram of hemoglobin, but here we frequently exceed that limit. And for radiation therapy studies, for a long time, we had that objective. Tumor oxygenation. You know the oxygen effect? It is a radio-sensitizing effect. And in my younger days, I found that hydrogen peroxide was injected into tumors to make them radiosensitive. So a lot of studies have looked at that. So there's already a significant gap relative to the current guidelines in terms of the use of these molecules, these agents. So in terms of hemoglobin rate, the rate is relatively low. And in terms of PFS and or overall survival, there are consistent gaps, 8 out of 60 randomized studies. Needless to say, with this type of a situation, we try to use a meta-analysis to try to better understand whether or not it's a consistent and a significant impact. Various meta-analyses have been carried out, some of them by industry themselves, at the request of public authorities, particularly the Food and Drug Administration. This is the most exhaustive meta-analysis carried out by Amgen as well as J&J, and also Cochrane, as the added benefit of being an independent organization. So the most recent meta-analysis shows that, indeed, there is a problem in terms of overall survival. It seems to significantly alter in all studies. And again, the 8 studies that we talked about have a significant impact. However, when we limit the data to chemotherapy studies, that is, using the drug under normal circumstances, the problem disappears. So there's a clear recommendation. ESAs should not be prescribed under those circumstances as an adjunct to chemotherapy. Radiation therapy, pardon me. This is the key takeaway we're taking back from this period. There's another recent meta-analysis by Glasby, published in the British Journal of Cancer. And the graph is hard to read, I know, but there is no harmful impact on survival when you prescribe ESAs for over 15,000 patients. So no impact on overall mortality, no significant impact. Also, what we looked at is the tumor progression. No obvious pro-carcinogenic impact, but there is one impact that is well known and constant: the increased risk of venous thromboembolism. 48% in the study, 55% in a different meta-analysis, Bennett's, and also between 48 and 55%. We are pretty consistent from one study to another. This is the Bennett meta-analysis. The hazard ratio is 1.57 for the venous thromboembolic risk. So when we prescribe ESA plus the patient is transfused, this means an increased risk of thromboembolic events. So let's be careful in terms of post-op sequelae and anti-angiogenics, the whole cocktail, not forgetting age. When the patient is 70, bedridden, receives Avastin plus an ESA, by definition, that's a recipe for disaster. Let's just say it's an explosive situation. So if we look at the relationship between thromboembolic events and mortality risk, well, the APRO meta-analysis, for example, only looked at epoetin beta, and there's clearly more thromboembolic events in the ESA group, but no causation link with mortality. In other words, the problems observed in other studies are compensated by a mortality mediated by thromboembolic event. So if there is no relationship with a thromboembolic event, is there a tumor stimulation by the ESA? Is there a biological rationale? The answer is yes. There is a rationale, but there is no evidence to this point, no evidence of the connection, whether with animal models or clinical situation. However, when the EPO receptor is stimulated, this can lead to autophosphorylation of JAK2 and in particular stimulate tumor proliferation. There's another possibility. Anti-apoptotic phenomena may be stimulated, which in theory at least could explain But again, it hasn't been demonstrated clinically. There could potentially be a tumor simulation. However, particularly for meta-analysis, there is no signal in favor of an increased tumor progression due to ESAs. Now, for those of you who are interested in the biology, there's an interesting summary carried out by Matti Apro. He looked at erythropoietin receptors and ESAs on disease progression in cancer. At the beginning, when ESAs started being developed, we thought it might have an anti-tumor impact, but there's no certainty about it at this time. So the various guidelines have been modified by the various learned society. Whether ASCO, EORTC, or NCCN, the target rate, the initiation rate for treatment is lower, clearly under 10 gram, and the target treatment should not exceed 12, even 11 gram per DL. That's for ASCO. So I compare the different guidelines, not to give you the details, but also to show you that there is a consensus between the different guidelines on what should be done. ASCO is relatively stringent. It's a stickler for rules, and it is the lowest hemoglobin rate that makes it possible to avoid transfusions. So ASCO is very, very strict about that. It's a strict guideline. Do we have more recent data? Yes, we do. In particular, this study was shown in San Antonio, but it hasn't been published yet. The data has yet to be fully mature, by Brian Leyland Jones. This is the continuation of the BEST study. It's a major scientific development being suggested by this team. So we're talking metastatic breast cancer. This is a phase 3 study. The patients will receive a chemotherapy plus epoetin, at least an anti-cancer treatment plus epoetin versus placebo. So what is the history? Well, our history is the BEST study a couple of years ago. This is a funny result. No PFS difference for breast cancer patients, but there's a significant difference in terms of overall survival. Hazard ratio 1.37. So how do we achieve that? An OS difference, but no PFS difference. That was not the primary endpoint, so this raises a lot of issue. So if we need to look at a study that does look at that, with the survival as its primary endpoint. So this study did that. Randomization. Standard chemotherapy plus epoetin alpha, that's the first arm, high weekly dose, versus standard chemo plus placebo. Now, the primary endpoint, PFS, of course, and secondary endpoints, overall survival, etc., etc. This is a non-inferiority study. That's very important. And the non-inferiority margin is 15%, which is rather reasonable. And there's a significant number of patients who were included in this study. Now, curiously enough, duration of treatment, ESA treatment was usually under 3 months. The hemoglobin doesn't go up much, only 1 point. Not many thromboembolic events, not many deaths because of that, and also surprisingly, the non-inferiority target. When the data was presented, the target was not achieved, and there is a slight difference. We can't say much about that slight difference at this point, but a slight difference not in favor of prescribing epoetin alpha. So the findings from the authors are rather formal, even at the time when they presented the data. So Leyland Jones, at the time of the BEST study, said that you have yet to convince me that there is indeed a harmful impact. But when this data was presented, the finding is, I'm not going to go into detail, but we need to be extremely circumspect. We should avoid prescribing ESAs when survival can be improved, particularly in head and neck problems, particularly breast cancer. So this is a very circumspect, very cautious, very restrictive stance that this team is taking. Meanwhile, other data has been published, well, in 2014 by a German team. A different phase 3 trial, the prospective phase 3 WSG ARA trial. So looking at the treatment of early breast cancer as an adjunct, not just for metastatic breast cancer. So it's interesting. The design is relatively similar. The drug is different. This is not epoetin alpha. This is darbepoetin in association with TAC or the Canadian CEF versus placebo. So randomization is balanced. There's a significant number of patients, but if we look at the primary endpoint, we find that this is not a non-inferiority design. It is a superiority design in favor of the ESA with a 6.5% difference, which is considerable. 6.5%? That's half of the average benefit of adjunct chemo, irrespective of the stage or histological criteria. So if you initiate an ESA and you get 50% of the benefit from chemo, I'm having a hard time with that. So at the end of the day, it's not surprising that we're getting these results. In other words, there's no difference. No difference for superiority study doesn't mean that there's no difference whatsoever, okay? There are no threatening signs, and so we're reassured, but we can't say that the method is absolutely pure, as it was in the Leland-Jones study. So whether in terms of ITT or PP, there's no difference. And also in an exploratory study, a non-pre-planned study, there is a difference in favor of darbepoetin in the group of patients who are hormone negative. This was found by the authors in their paper. And this finding, this conclusion, completely different than before. In reality, up until now, for our German friends, there were a number of restrictions, and these restrictions now appear to be lifted, in their opinion, and they believe it is a good alternative to transfusion for most patients. And at the end of the day, we shouldn't be too worried. So it's hard to forge an opinion after all of this. If we look at literature, as it stands, what do we see? For metastatic breast cancer, the best study found an excess of early mortality, but overall survival was not the only endpoint. In the other study, PFS is reduced, but non-inferiority has not been established. As a neoadjunct, there's another called PREPARE, and it found a lower DFS, but barely significant, not in favor of the ESA. And also as an adjunct, the German study, it's a randomized study, does not find superiority, but does not find inferiority either. And there's another exploratory study that I'm not showing you, which has not shown any difference. If we look at the different studies, clearly in the latest studies on hyperstillation, we're not talking 15 grams of hemoglobin. There is no obvious tumor hyperexpression of EPO receptors in the tumor. Not the tumor per se, but the data published. Now, I'd like to refer you to the Mattia Pro meta-analysis published in 2014, and this time the interest is that it looks at EPO-A, EPO-B, darbepoetin, and biosimilars. It is the very first study that looks at all of this. Now, the best study was excluded because from a methodology point of view, it was found insufficient. And after excluding best, there is no difference. So at the end of the day, this is my opinion, and I know you don't care because you'd like to stick to the recommendations, wouldn't you? There is still reasonable doubt when it comes to epoetin alpha. If we really believe in evidence-based medicine, the only study that is beyond reproach from a methodological point of view is EPO-NE. And it shows a harmful effect, but it has been published. And in breast cancer, as an adjunct, if we believe literature, and also for metastatic breast cancer, where the overall survival benefit is significant, the EMBRACE study showed that even as the second, third, or fourth line, survival is improved, even for metastatic breast cancer, and it is preferable to avoid. And that's my instruction to our young friends. Better avoid it. For other advanced cancers, no major restriction, because no data is available. We should probably discuss this together with our peers and also with patients. Should there be a curative treatment? The alternative is transfusion, and transfusion reduces survival and increases the risk of thromboembolic events. This has been shown by various studies. So during the ESA phase, it's not as though there was nothing else happening. No, transfusion is happening, and so young prescribers should be educated to comply with the guidelines and to really stick to the guidelines. So guidelines from ESMO, they've already been published 5 years ago. I'm not going to dwell on that, but at the end of the day, there is nothing new under the sun in terms of these guidelines. As a curative intent, prescribing should be done with precautions. And once you've said that, well, we're all very happy. Hence the smiley. I'm not going to go too much into detail here, but there are specific recommendations on how to use iron. mostly through IVs combined with ESAs. I don't have time to dwell on this, but there's a lot of literature on that, and I believe the presentation will be available for you, to you, rather. So Mathieu Pro gave a presentation in a recent Congress, looked at potential changes in guidelines in connection with EORTC. And I hope we can show you some of that information. In particular, for patients with very low hemoglobin, we may think we may consider combining the two. Now, for curative purposes, there is no argument for systematically rolling out ESAs and no argument to use it systematically either. So we need to be circumspect and remember that the target HB concentration ranges between 11 and 12 gram per DL, and we need to be able to discontinue treatment as soon as you reach the upper limit. So no major change at the end of the day. Let's just remember that when we focus on other agents, in particular darbepoetin as well as epoetin beta, there is no specific data about a harmful impact. Also, let's remember that the risk of thromboembolic events is increased. We said that before, so let's focus on all of the additional risks of thromboembolic events, and also remember that we should use these agents in line with the guidelines and the recommendations and the labels. You're familiar with the various agents available, whether biosimilars or Princeps molecules. We need to be careful with the dose, particularly when using injections. And this is the diagram that we all know, EORTC recommendations. And these guidelines remain unchanged. A couple of details maybe regarding the strategy we should use for symptomatic patients or non-symptomatic patients. And this is just a summary of what I said before. The message I'd like to get across is this. This is not don't stick to what industry tells you. These drugs are at least as important as anti-cancer medicines when you look at the side effects, which means that each department of the hospital needs to be well argued and needs to be well established. So every year we give a specific class to our junior doctors. Don't decide to prescribe ESAs unless it's been validated by a senior physician. Thank you. And I hope I didn't take too long. Many thanks, Gilles, for the crash course. I have a couple of observations. We're going to take a couple of minutes to discuss quickly. The first thing we need to do is evaluate what causes the anemia, the iron deficiency or hemorrhaging, and we need to rule out the cause of anemia before you can actually consider an ESA treatment. Now, if the issue of survival hasn't been demonstrated, quality of life, that's been explored, and that's done and dusted. So maybe we need to focus not just on the hemoglobin level, but also the context, the patient's own environment, his daily life, particularly for patients being treated as an adjunct for breast cancer. And as you well said, as you well demonstrated, maybe we need to look at not just the hemoglobin level, but also the patient's circumstances. A quick word about transfusion. A study looked at GI patients, GI bleeding patients. So we're not talking ESAs, we're not talking about cancer. But there was a comparative study, 2 arms. One arm of patients being transfused, 9 gram of hemoglobin, and another arm with a strict transfusion, only 7 gram. And the difference in survival was not in favor of the patients who received 9 gram. And this is not cancer, this is GI bleeding. And this year, there's a poster, which was not presented at ASCO, but it is included in the book of abstracts. And for breast cancer patients, as an adjunct, we find there's a survival difference of several years, not in favor of patients who were transfused during the treatment. And we need to be extremely vigilant. Let's be careful in terms of anemia, generally speaking. And there's also been studies on iron. Let's not forbid this strictly. Talk to the patient and make sure that the patient follows the rules. Make sure we follow the guidelines. There is one stumbling block, however, a shared decision. Very often we come up with the following finding. We need to discuss this with the patient, etc., etc. But we already explained adjunct chemo, radiation therapy, etc., etc. It's so much information for them. And now we're going to tell them that, and this is so hard to understand, even for oncologists. So adding one extra layer of complexity is tough. We have time for one question. Many thanks, Gilles, for this amazing presentation. I agree. We need to emphasize the patient's assessment when the patient is fatigued and there's no anemia. There may be an iron deficiency, an unrecognized iron deficiency. Very often, the clinical signs are very similar to anemia, and because there's no anemia, the problem may not be diagnosed properly. And I think that in America, the transfusion threshold is being further reduced to 6 or 7 grams, which is, well, difficult to consider here. I agree with you. When we give this type of presentation, we only talk about ESAs. So we focus our attention on ESAs. A couple of years ago, these agents were prescribed left, right, and center, and now there's a pendulum effect. The competing method is a transfusion, and transfusion is bad. Don't get me started on the risk of infection. There was a real problem. I had a case of hepatitis post-transfusion. And the other thing I want to say about fatigue, never forget that the stress strain has to be factored in. And APA programs correct that in the most extraordinary fashion. Let me add my 2 cents. The 2006-2008 study by industry and also the recent industry that was just published in France by Florence Caltongue. In 2001, the ECA study shows that 60% of patients are not managed for their anemia, and later the rate was 60% for ESAs. And in 2012, now we have 58% of patients who are not being treated for their anemia. So again, let's keep our ear to the ground. Thank you. No more questions?